vitamin D receptor and toll-like receptor therapeutics for post-viremic COVID, calcifediol 25D and calcitriol 125D as treatments for impaired calcitriol biosynthesis pathways in post-viremic COVID patients. Part 3F, viral reactivations and boosting mucosal immunity. This is the final part of the third section of this presentation, dealing with the overall topic of vitamin D receptor and toll-like receptor pathways in COVID. In future presentations, we will discuss the biophysical chemistry of COVID as well as the biophysical chemistry of COVID therapeutics. As we discuss toll-like receptor and vitamin D receptor interactions and the recovery of cellular cytology and nuclear structure in the post-viremic COVID period. In this presentation, we will review approximately 45 papers, placing them in context with prior presentations, as well as recent news reports of the effects of Delta on vaccinated and unvaccinated populations. Key therapeutic concepts. 1. COVID spike protein forms the S1 toxin by proteolysis. The S1 fragment is the head segment of the spike protein. This S1 fragment, hereafter referred to as the S1 toxin, has multiple cytotoxicities, which induce damage to cells, tissues, and organs, as well as inducing endocrine impairments. 2. It is now known that COVID can reactivate herpes family viruses, in particular the Epstein-Barr virus, EBV. EBV reactivation is linked to increased COVID severity as well as the development of long COVID. 3. It is now established that multiple pathogenic modules of COVID can be arrested by stimulating vitamin D receptors with activated vitamin D, calcitriol, also known as 125D. 4. Replacement of deficient vitamin D metabolites, such as calcifediol and calcitriol, serve as a successful therapeutic strategy for the treatment of COVID. In 3E, this was the August 14 notes, we discussed viral reactivations during COVID. Nasal and oropharyngeal epithelia are incubation sites for COVID virions, as well as sites for the production of COVID toxins, including the S1 fragment. Listed here are a set of interlocking and overlapping pathogenic modules that can be viewed not only as a linear string, but involved in feedback loops. They involve COVID-induced chromatin remodeling, which can help reactivate dormant viruses such as Epstein-Barr. C. The reactivation of dormant viruses produces a state of polymicrobial sepsis. Polymicrobial sepsis can also involve bacteria and fungal growth in localized regions of COVID infection. Hypoxic immunodeficient niches are one site where polymicrobial sepsis can be initiated. Toxins produced by the polymicrobial infection lead to polymicrobial toxemia, which can have widespread pathogenic actions on target organs. D. COVAN, COVID-associated nephropathies, which include acute Fanconi syndrome, damage to proximal convoluted tubules, as well as acute kidney injury, which is a more progressive form of the type of kidney injuries observed when in COVID infections. Injury to the proximal convoluted tubules in COVAN leads to impaired calcitriol biosynthesis because the proximal convoluted tubule cells are a major source of calcitriol synthesis and secretion into the serum. A lack of calcitriol in the serum leads to innate immune deficits, which can help promote the onset of polymicrobial infections. Lack of calcitriol also dysregulates the immunoendocrine systems. Loss of vitamin D receptor stimuli, calcitriol, leads to a depressed secretion of antimicrobial peptides, again promoting the development of polymicrobial infections. These can be referred to as secondary opportunistic infections. These in turn can contribute to hyperinflammation, coagulation, and hypoxia, all of which can establish multiple vicious cycles of histopathogenesis. How can these be treated? The use of hydroxylated vitamin D metabolites such as calcifediol 25D has been found to substantially reduce the mortality rate in hospitalized COVID patients. These are studies that have been conducted in Spain. We will refer to these studies throughout this current presentation. Here are impacts of COVID infections, updates on these subjects. In prior portions of this discussion, we have examined the pathogenesis of COVID in the lungs, kidneys, particularly damage to nephrons, glomeruli, proximal convoluted tubules, and peritubular capillaries, COVID infection in the eyes, capillaries in general, COVID infection in salivary glands, and in today's discussion, we will concentrate on COVID infections in the nasal cavity, producing sensory deficits known as anosmia, the loss of smell, and parosmia, abnormal smell. As mentioned earlier, the reactivation of Epstein-Barr virus is now thought to play important roles in the severity of COVID infections, as well as the genesis of long COVID symptoms. So throughout these discussions, it is important to identify physiological failure modes. For instance, the reactivation of dormant viruses, such as Epstein-Barr, indicate a major failure mode in the immune system, the loss of viral silencing, resulting in the reactivation of dormant viruses. 2, it is important to identify non-predictive models of pathogenesis. For instance, models that fail to predict the reactivation of dormant viruses must be examined for why the models are unable to predict this type of pathogenesis. 3, it's important to discuss both productive and non-productive COVID therapies, especially when examining the vitamin D pathway and interventions that are aimed at stimulating vitamin D receptors. So as we discuss vitamin D metabolite therapeutics for the treatment of COVID variants, particularly Delta, Delta plus, Kappa, Lambda, Epsilon, these more virulent, more transmissible, more pathogenic variants, it's important to concentrate on the more hydroxylated forms of vitamin D, calcifediol and calcitriol, and to emphasize that vitamin D3 is likely to fail in these more rapidly advancing COVID variant infections. For that reason, it is important to focus new effort on the actions of calcifediol, the metabolite which is found in the serum and is commonly measured by physicians as a measure of gauging vitamin D status in an individual. So visualizing COVID as a polymicrobial infection in progressive COVID patients or in long COVID patients, it serves as an opportunity to re-gauge the importance of utilizing vitamin D therapeutics, specifically 25D and 125D, as agents to suppress the reactivation of viruses, to suppress hypercoagulation, to suppress hyperinflammation. Clinical trials have now been reported from Spain. For instance, this paper describes calcifediol treatment and COVID-related outcomes, focusing on mortality and morbidity benefits. The therapeutic regimen is 530 micrograms of calcifediol on day 0. This is hospitalization. On days 3, 7, 15, and 30, in hospitalized patients, the patients are given 270 micrograms of calcifediol, 25D. There is a major drop in mortality and morbidity. The odds ratio depend on the group of patients that are included in the statistical analysis. I encourage viewers of this presentation to pause as these papers are presented to read the abstract in figures to gain a deeper understanding of the results and their ramifications. It is now clear that vitamin D therapeutics, by stimulating vitamin D receptors, VDRs, can serve as a potent means of decreasing COVID pathogenesis. One consequence of stimulating vitamin D receptors is the upregulation and secretion of antimicrobial peptides such as LL37, which are known to bind to the spike proteins of CoV-2 and neutralize them. It is important to look laterally at the use of vitamin D therapeutics in other viral infections, specifically Epstein-Barr, which is commonly found in multiple sclerosis patients. Epstein-Barr infects B cell lymphocytes. It infects many cell types in the body. However, the use of high-dose vitamin D3 supplementation can be used to examine antibody responses against the Epstein-Barr virus in relapsing remitting multiple sclerosis patients. It is important to emphasize the need to place immune cells in anatomical contexts, and I refer viewers of this presentation to consult this paper, which describes reactive astrocytes, meaning inflamed and immunoactive astrocytes, which surround inflamed perivascular spaces. A perivascular space is the compartment between the outer surface of a blood vessel in the CNS and the basal lamina. The leukocytes and lymphocytes from the serum can penetrate through the boundaries of endothelial cells and enter this space and accumulate. In multiple sclerosis patients, there is a large aggregation of leukocytes and lymphocytes in this perivascular space. It is known as a perivascular cuff, very distinctive. The Epstein-Barr virus modifies the cellular behavior of immune cells and contributes to the unusual pathogenesis the perivascular cuff, which is distinguished in multiple sclerosis patients. We will discuss the actions of vitamin D3 on MS patients later in this presentation. Throughout these discussions, it is important to emphasize the need for hybridized theoretical frameworks. The epistemologies and analytical frameworks as a means of moving between various levels of biological order from the nanoscale to the meter scale. These fields include immunology, physiology, and cell behavior as they are modified by viral infections. So bringing in the concepts of virology, a field known as virophysics, which are the biophysical features of viral infections and propagation and dissemination. And to understand COVID therapies and therapeutics is also necessary to hybridize concepts with the fields of biophysical chemistry and pharmacology. In prior presentations, we have also discussed toxicology, and here we are emphasizing the need to include failure mode analysis, which is commonly used in fields of engineering to examine when processes like an intervention, in this case a pharmacological intervention, fails to produce desired results. So, point 2, Epstein-Barr virus can be reactivated during COVID. Epstein-Barr virus reactivation is linked to increased COVID severity as well as long COVID. These 3 papers discuss these issues, the severity of COVID as well as long COVID being linked to the reactivation of Epstein-Barr virus. Clinically, it has now been found that the phenomenon of COVID toes, which are let's say, a common sign of COVID infection, but a sign of persistent COVID infection found especially in children. It's now been found that the Epstein-Barr virus has been reactivated in these children, and this is now giving a new understanding of the etiology of this syndrome. So not only dealing with COVID virions at some point in the genesis of COVID toes, but the effects of Epstein-Barr virus co-infection. And again, this is a reactivation of Epstein-Barr that has lain dormant in the genome of infected cells until it was provoked into re-expression by the COVID infection. So viewing CoV-2 as the primary infectious agent and Epstein-Barr as the secondary or opportunistic infection, synergizing to produce this clinical presentation. Shifting now to the Delta variant, Israel. The outbreak of Delta in Israel has prompted the Israeli government and medical institutions to issue a 3rd set of Pfizer vaccines. So they're referring to these as Pfizer booster shots. So Israel is now starting the administration of a 3rd shot to people. And in the US, the announcement has also been made that within months, previously vaccinated people will be encouraged to take a booster shot. Why is this? The virions of Delta have a much more stable shape in the spike protein. Its receptor binding domain remains in an extended position, making it able to bind to H2 receptors more effectively. This allows virions to dock with cells and presumably allow them to enter cells more easily, resulting in an overall increase in infectiousness. It should also be mentioned that as the spike protein is severed and formed S1 fragments, it is likely that the S1 toxin resulting from this spike protein is likely to also bind more effectively to receptors such as ACE2 or toll-like receptors. But this is a key piece of information that needs to be established and tested at the cellular level. How the S1 fragment affects cellular physiology and whether the S1 toxin from a delta virion is more potent in its pathogenic activity than the S1 toxin from, say, an alpha variant. And it is now clear that the focus of future therapeutics needs to be directed at the nasal cavity as well as the oropharyngeal cavity because the surfaces, the epithelial surfaces in these cavities are a primary site in which the virus incubates and starts to exert its pathogenic activity. Can vaccinated people spread Delta? What does the science say? People who have Delta virus and happen to have breakthrough infections can carry these really high levels of virus and can unwittingly spread the virus to others, says David O'Connor, a virologist from the University of Wisconsin at Madison. In this highlighted quote, Delta viral loads were similar for both groups. This means vaccinated people and versus unvaccinated people during the first week of infection, but dropped quickly after day 7 in vaccinated people. Given the high virus levels seen in the first week of illness with Delta, measures such as masks and hand hygiene, which can reduce transmission, are important for everyone, regardless of vaccination status. The bottom line is that this can happen. It can be true that vaccinated people can spread the virus, but we do not yet know what the relative role in the overall community spread is, says co-author Thomas Friedrich. This is the paper which is being discussed, preprint. Shedding of infectious SARS-CoV-2 despite vaccination when the Delta variant is prevalent. So with the Delta variant, it is possible that even by day 3 of infection, the infection has spread to the lower respiratory tissues. And in this diagram illustrating the concept that infected lower respiratory tissues, pulmonary tissues, can generate virions, but viral materials, including spike proteins, spike protein fragments, double-stranded RNA, nucleocapsid protein, membrane protein, envelope protein, all of this viral debris material, as well as virions, can now move through the circulatory system, through lymphatic vessels, circulatory vessels, and hit a variety of visceral organ targets. One site of injury is the kidney, producing an acute kidney injury, which nephrologists define in various ways, and we have discussed several types of nephropathies, particularly collapsing glomerulopathies, injury to proximal convoluted tubules. Again, it's not only the virions that are capable of producing injury. It is now thought that the predominant mechanism of kidney injury is through viral materials, such as the S1 spike protein toxin. and impact through on the endothelial cells in the glomeruli, the capillary bed there, or through the perivascular capillaries, the endothelial cells there. These are two ways by which circulating viral toxins can exert very damaging impact on the kidney. Proximal tubular dysfunction in patients with COVID. What have we learned so far? It has been determined that in the proximal convoluted tubules, there is a loss of microvilli as well as dilations of the tubule and sometimes coagulation. All of these injuries will impact calcitriol biosynthesis, resulting in a cascading set of impacts on the immune system and the endocrine system. I'd like to point out two other sites on YouTube, which are places where two pulmonologists are discussing COVID pathogenesis and the results of COVID interventions. Dr. Mike Hansen is one site that I would encourage viewers to follow. And Dr. Svelte at UC Riverside. And Dr. Svelte is a pulmonologist, and he discusses the variants and how they compare to prior in viral infections with less pathogenic variants. He also discusses the need to utilize vitamin D supplements as a means of attenuating the impact of COVID. In this YouTube channel known as MedCram, this is an interview with Eric Topol, and there is a discussion of impacts of the Delta variant. And Dr. Topol, in the Scientific American article with Daniel Oran, stated that to beat COVID, we may need a good shot in the nose, meaning that intranasal vaccines might be used to help stop the spread of the coronavirus more effectively than needles in the arm. The idea is that the mucosal immunity needs to be boosted, particularly by the production of IgAs. IgGs in the serum are doing a wonderful job in suppressing the progression of COVID towards hospitalization or death. However, it is clear from the Wisconsin study that even in fully vaccinated individuals, COVID can gain a foothold in the nasal cavity and spread and replicate there for up to a week before it is suppressed by the adaptive immune system. So boosting the innate immune system and boosting mucosal immunity, this could be immediately accomplished potentially by the use of vitamin D metabolites. Why should this be looked at immediately? This study from India indicates that key antimicrobial peptides known as defensins are downregulated in the nasal cavity of infected COVID patients. Now, this is quite remarkable because normally when a viral infection occurs in the nasal cavity, there is an upregulation of these defensins, these antimicrobial peptides. Here, multiple defensins are being depressed. One mechanism by which this could occur is by the depression of calcitriol biosynthesis, which takes place in nasal epithelia and in immune cells in these tissues. Whatever the source of calcitriol, which is normally producing defensin production, it may be possible that there is both a local and a systemic drop in calcitriol, resulting in the downregulation of these multiple antimicrobial peptide genes. So numerous groups and companies are developing therapeutic agents, strategies to inactivate or arrest the COVID infection. These could be immediately adapted to deliver calcifediol 25D and or calcitriol 125D to bathe the nasal epithelial cells in a stimulant that would activate through vitamin D receptors the upregulation of antimicrobial peptides, including LL37, which plays important roles as an antiviral, antibacterial, antifungal, and anti-inflammatory agent. In future presentations, we will discuss the biophysical chemistry of COVID and COVID therapeutics, such as these vitamin D metabolites, how to solubilize them, how they can be dispersed, how they would interact with the nasal epithelium, penetrate deeper into the layers of the nasal epithelium to evoke these potentially beneficial effects. New York Times article, What Do We Know About Breakthrough Infections in the Delta Variant? Okay. Early in the infection, when people are most likely to be contagious, the Delta variant seems to replicate in amounts that are perhaps 1,000 times as much as those seen in people infected with other variants, defeating immune defenses in the nose and throat. I will insert there that this is defeating antimicrobial peptides like the defensins and LL37. It's just way more virus than going to potentially overwhelm that initial firewall, said Jennifer Gummerman, an immunologist at the University of Toronto. To prevent both severe illness and infections, the vaccines would need to produce long-lasting antibodies in the nose, the blood, and the nose. That's a really tall ask for a vaccine, Dr. Gummerman said. Again, the immune defenses include antimicrobial peptides, and one way to boost them is to stimulate vitamin D receptors, either through oral vitamin D metabolites, calcitriol, calcifediol, as well as topical agents delivered through into the nasal epithelium by aerosols. The goal should be to reduce the production of circulating toxins, such as the S1 toxin. And that provides an opportunity, because the nasal cavity is so directly accessible, for analysis through nasal swabs, measuring the amount of defensins being produced, the amount of S1 toxin being produced, the kinetics by which these vitamin D metabolites act, and the way they can alter the spread of the S1 toxin through the body. I will refer now to the S1 toxin. This is the spike protein S1 fragment as the S1 toxin parenthesis delta, indicating that it is the S1 fragment derived from the Delta variant. It is important now to distinguish which toxin derived from which virion, which variant is involved. And this reconstruction of the interaction of the S1 toxin with the ACE2 receptor was done prior to the emergence of the Delta variant. So in understanding the pathogenicities, the cytotoxicities of the S1 toxin Delta, it is necessary to look at how its receptor binding domain has been altered through the mutational processes. This is a very nice diagram because it succinctly illustrates how calcifediol 25D, a therapeutic that is already in play in Spain to treat COVID patients with major success, how it is converted to active 125D in the cytoplasm of cells through the action of an enzyme, 1-alpha hydroxylase, which is present in the inner membranes of mitochondria as well as in the endoplasmic reticulum. The synthesis of 125D calcitriol produces the natural agonist for the vitamin D receptor, VDR, which activates target genes, up to 2,000 of them in the 20,000 gene human genome, by interacting with vitamin D responsive elements in the promoter regions of target genes. The liganded vitamin D receptor, which is bound calcitriol, now activates the expression of an antimicrobial peptide which acts both intracellularly and after cleavage extracellularly, and the HCAP18 cathelicidin acting intracellularly and its fragment LL37 acting extracellularly are playing key roles in attenuating the action of both the COVID virion as well as the S1 toxin derived from the virion spike proteins. So boosting these antimicrobial peptides by stimulating vitamin D receptors, by providing vitamin D metabolites as therapeutic agents, is a strategy which is, quote, AMP-centric. The idea is to focus on boosting an innate immune system's defenses by boosting these antimicrobial peptides, which are antiviral immunotherapies. So ramping up antimicrobial peptides against severe acute respiratory syndrome, CoV-2, is the subject of this mini review. And it emphasizes that there are several antimicrobial peptides that are being produced in various cell types, respiratory epithelia, immune cells, that are able to either bind to the spike protein and prevent its interaction with the H2 receptor, or to cloak the H2 receptor and prevent the COVID virions or the S1 toxin from binding to the H2 receptor and disrupting cellular metabolism. A dynamic view of spike protein reveals prime targets for COVID treatments. This shows the reconstruction of the COVID spike protein in a virion membrane. And the strategy to inactivate it or neutralize it is through the generation of neutralizing antibodies, or NAbs. And this shows various sites where neutralizing antibodies, NAbs, can bind to and inactivate the COVID spike protein. It's also possible to inactivate, neutralize the spike protein through the production and upregulation of antimicrobial peptides, such as LL37. The advantage of using AMPs to neutralize the spike protein is that they are already present in the human genome and just need to stimulate their expression epigenetically. So it is critical to understand humoral immunity against COVID as being produced by both AMPs and NAbs, antimicrobial peptides, and neutralizing antibodies, recognizing that AMPs are also a potent means by which viral proteins can be neutralized. So host factor means of counteracting a viral infection bring us to the endocrinology of viral infections. And so this is a molecular and cellular battlefield where an invader is interacting with defenses and defenders. And it is necessary to look at this through integrated omics and integrated physiology. Utilizing core principles from endocrinology, such as the biosynthesis of calcitriol, involving this canonical pathway, the well-known, well-established pathway that vitamin D3 produced in the skin or obtained through oral intake is converted to calcifediol 25D in the liver through a hydroxylase encoded by the gene CYP2R1. So the 25 hydroxylase is responsible for this action. The liver metabolite, 25D, is taken to the kidney and it has a second hydroxylation, becoming 1,25D, calcitriol. And this conversion is produced by the hydroxylase encoded by the gene CYP27B1. There's a parallel pathway by which the 25D metabolite, also not illustrated here but present, is that vitamin D3 as well as 25D can be taken into the cytoplasm of immune cells and epithelial cells and converted to calcitriol in mitochondria and ER, and this is the non-canonical biosynthesis pathways. Both of them result in the active agent calcitriol, which interacts with vitamin D receptors, which have beneficial actions by the production of several types of antimicrobial responses, including the upregulation secretion of antimicrobial peptides. But what happens when you have a viral infection, such as Epstein-Barr virus being reactivated in COVID? Epstein-Barr virus has evolved to interfere with vitamin D biosynthesis pathways, for instance, by suppressing the synthesis of 25D in the liver. These are additional sites by which Epstein-Barr virus proteins interfere with vitamin D receptors or compete with vitamin D receptor for binding sites in the nucleus, preventing vitamin D responsive genes from being activated. So, by multiple means, Epstein-Barr virus is crippling calcitriol biosynthesis, crippling vitamin D signaling pathway, and it does so in regions where the Epstein-Barr virus has been reactivated from a circular piece of DNA known as episome, which lies close to heterochromatic regions on chromosomes, waiting for stimuli to become reactivated. So, by some means, COVID infections are reactivating this virus, and by doing so, it brings an auxiliary set of pathogenic troops into play in various immune cell populations, various tissues, and in this way further debilitates the body's ability to fight the COVID infection. So going back to the paper on using high-dose vitamin D3 as a treatment against Epstein-Barr virus in relapsing remitting multiple sclerosis, and what the authors did was look at Epstein-Barr proteins, EBNA1 and EBNA1 fragment, which are part of the Epstein-Barr genome, and comparing them to other proteins from other viruses in these cells, such as the cytomegalovirus and varicella zoster. And what they found was that the vitamin D3 supplementation was able to suppress the expression of the Epstein-Barr virus proteins, whereas there was much less change in the expression of the other viral proteins. So this illustrates that in the case of vitamin D supplementation, the Epstein-Barr virus seems to be suppressed in multiple sclerosis patients. So, point 2, Epstein-Barr virus can be reactivated during COVID, and there are several references presented earlier how this Epstein-Barr virus reactivation is linked to increased COVID severity as well as long COVID symptoms. And we have seen that there are multiple pathogenic modules in COVID that can be arrested when vitamin D receptors are stimulated with calcitriol. That can be achieved by supplying precursors such as D3 or 25D to COVID patients. However, with the more pathogenic strains of COVID, such as Delta, it is more likely that 25D and 125D will likely be the superior therapeutic agents to help suppress Epstein-Barr virus reactivation or suppress it after it has been reactivated in, say, post-viremic COVID patients. So as we move to point 4 or section 4 in this overall discussion, as we discuss the interaction of vitamin D receptors and toll-like receptors, we will be shifting to a cell-centric type of analysis, which is also linked to an organelle-centric analysis. But just briefly here, illustrating that both autophagy and antiviral actions of vitamin D in a macrophage responding to a viral infection, you see all of these agents coming into play, involving epigenetic changes in hydroxylase levels, preparing the cell for its combat with the viral invader. Note also that much of the combat is also taking place in intracellular compartments such as endosomes and autophagosomes. And what we will see in COVID, that there is a major dysregulation in the trafficking of the virus and the production of virions and their hijacking of various organelles, ER, mitochondria, and lysosomes, to carry out their replication. What links COVID to Epstein-Barr reactivation? This paper is one of the first to make this linkage. There was a correlation between interleukin-6 levels and the levels of Epstein-Barr virus in COVID patients. So this is an analysis of serum. This now needs to be examined at the cellular level to see more of the molecular epigenetics involved in the reactivation of Epstein-Barr, particularly how the episomes in the infected cell lying on heterochromatic regions of chromosomes become reactivated. So what is new? It was now realizing that in progressive COVID patients frequently and in post-viremic COVID patients, when COVID virions are no longer observed in the serum, that the legacy of COVID may be the persistent reactivation and expression of Epstein-Barr virus. So overall, we are looking at the dynamics of a set of processes that are interlocking, much like a jigsaw puzzle. And to solve a jigsaw puzzle, it is important to obtain contextual information from a variety of features of information. An analogy to the jigsaw puzzle is very difficult to assemble a jigsaw puzzle by just looking at the shapes of the pieces, such as the back side of the pieces. Much more easy to solve the puzzle if you have contextual information to see how the pieces fit together. So as we look at CoV-2, we know that COVID, the entire set of human maladies that arise from this viral infection, revolve around aberrant cell behaviors and aberrant physiology. And we now know that latent viruses are being reactivated from the genome, and particularly the Epstein-Barr virus. And we know that it directly modifies vitamin D biosynthesis pathways, crippling it by altering hydroxylase dysregulation as one mechanism, and by interfering directly with the vitamin D receptor as another. We know that these are taking place in the nasal cavity. We know that the Delta variant and other variants, that this is going to be a key place where we need to bolster mucosal immunity, not just adaptive mucosal immunity, but innate mucosal immunity. So it is important to draw from the strong background and strong knowledge base of endocrinology, and yet putting words or symbolics illustrating various metabolites into this framework. Vitamin D3, 25D, calcitriol 125D, as well as the pathogenic agents, CoV2, its spike protein fragment, the S1 toxin, interleukin 6, reactivating Epstein-Barr, vitamin D receptors activating AMPs. We can see the elements of this molecular cellular battlefield. However, to create narratives, to understand the trajectory of a patient's symptoms, it is necessary to turn those pieces over, to look at the details of each metabolite, each process by which the metabolite is modified, how it's degraded, how it's transported, its life cycle. This fits into integrated omics, metabolomics, transcriptomics, epigenetics. Putting that in anatomical context, for instance, and with the turbinates and the myotices and the sinus fluids that produce the physiological functions of the nasal cavity, we can begin to examine a pathogenic process in COVID, which is now seen to be very common, anosmia, the loss of smell. So COVID can warp the senses even after recovery. Bizarre smells and tastes. Some say that they're smelling odors that aren't there, which is a distortion called phantosemia. They're smelling cigarette smoke constantly or rotting garbage. So any abnormality in the sense of smell is known as parosmia. The loss of smell is anosmia. A year after I contracted COVID, everything still smells like garbage and onions. One expert says this could last up to 3 years. What is going on? Some of this can be directly addressed by studying histopathogenesis in a rodent model for COVID, the golden Syrian hamster, which can be directly infected through aerosols delivered to the nasal cavity. Looking at the impacts of the viral infection on the olfactory epithelium, a stratified epithelium that lies on other tissues in the nasal cavity. So in the Syrian hamster model of COVID, loss of the olfactory epithelium is similar to COVID-induced pathogenesis in humans. So the loss of the olfactory epithelium results in a loss of olfactory receptors and can account very readily for anosmia, the genesis of anosmia. And so this diagram shows how the thickness of the olfactory epithelium changes as a course of time during a COVID infection. 3 days post-infection, DPI, there is maximum damage. The thickness has thinned dramatically. But over the course of a couple of weeks, cells begin to regenerate from stem cell populations and regenerate the differentiated structures necessary to have functional olfactory receptors in this olfactory epithelium. And this is illustrated here. The histological time course over this 2-week period, rapid collapse of the olfactory epithelium after initial infection, and then the rebuilding of the olfactory epithelium, its regeneration. And so these are sections through the head of the Syrian hamster, looking at the turbinates, the myotices, and you can look at the thickness of the olfactory epithelium as a function of time at days early on in the infection, DPIs, days post-infection, and during the regenerative process. Another paper dealing with these subjects. Now, this paper analyzes subcellular features of what's going on inside the olfactory epithelium. Disruption of nuclear architecture as a cause of COVID-19 induced anosmia. So the COVID infection obviously is resulting in apoptosis of certain cells, but the disruption of heterochromatin and the changes in the regions of the chromatin involved in active transcription becomes completely deranged in COVID infections, and how much is due to direct viral infection, the effects of cytokines, or the effects of toxins such as the S1 toxin or nucleocapsid protein binding to toll-like receptors. So it's important to realize the toxemia coming from the virus is working in tandem with the inflammatory cytokines to produce this histopathogenesis. And this understanding of a subcellular histopathogenesis, or the subcellular drivers of histopathogenesis, is needed to help understand the persistence of anosmia or parosmia as a function of time. And in this paper, clinical outcomes for patients with anosmia, COVID-induced anosmia, 1 year after COVID diagnosis. And so, unfortunately, the loss of smell or the disruption of smell can persist. And however, this post-viral anosmia, the loss of sensation of smell, did not begin with COVID-19. It is well known from other viral infections. And in this paper from 2007, the authors identified 10 classes of viruses, including influenza virus A and influenza B virus, Epstein-Barr virus. All of them were confirmed by looking at virions and viral nucleic acids in the mucus obtained from patients that had nasal viral infections. So identification of Epstein-Barr was one of the ways that this, one of the major results of the study. This table from the study illustrates individuals having different types of viral infections, but all of them showing olfactory dysfunction. So the infection of the olfactory epithelium, as well as its shedding, partial shedding or complete shedding, may be a strategy by which the mammalian olfactory epithelium is episodically lost to help combat an acute viral infection. So highlighting this quote, also the present study suggests that respiratory viruses, RVs, cause olfactory dysfunction through mechanisms other than nasal obstruction, and that respiratory viruses can induce various severities and time courses of olfactory dysfunction. So this statement summarizes what is now known for COVID anosmia and parosmia. And moving back to the important news about the Delta variant, the shedding of infectious CoV-2 virions despite vaccination when the Delta variant is prevalent. And this is a study from public health officials and researchers in Wisconsin. And as I looked at cycle thresholds and the PCR reactions, and they're looking at the amount of cycle time for the fluorescence in these assays to reach a critical value, they began to create a profile of the amount of RNA, viral RNA, present in a nasal swab. And when you look at compare vaccinated patients versus unvaccinated patients, both groups infected with the Delta variant, you see that it's almost identical. There's no statistical difference in the amount of RNA within the population. There are differences between individuals, of course, but what is remarkable is how many virions are present in vaccinated individuals who have contracted the Delta variant. So is this a case of breakthrough, or the fact that COVID vaccines really never adequately produced mucosal immunity from the Delta variant? And it is maybe that the strategy of obtaining humoral immunity for the serum and tissues bathed by the serum is not applicable to the immunity which is needed to suppress the virions in the nasal cavity. IgA-based immunity or AMP-based immunity. So these are very important findings as it pertains to future strategies to make the nasal epithelium a non-permissive environment for the replication and propagation of COVID. And this is from that same Wisconsin study, which was dealing with viral loads obtained from Delta infected individuals, both vaccinated and unvaccinated persons. Our data substantiate the idea that vaccinated individuals who become infected with the Delta variant may have the potential to transmit SARS-CoV-2 to others. And this is a very conservative, obvious statement once you look at the data. Important messages. Vaccinated individuals should continue to wear face coverings in indoor and congregate settings while also being tested for COVID-2 if they're exposed or experience COVID-like symptoms. It is clear that the nasal epithelium is a permissive environment for the Delta variant, even if a person has been fully vaccinated. To boost innate immunity or induce immunity of the nasal epithelium against COVID, it is probably going to require a combination of approaches by boosting antimicrobial peptides, by stimulating antiviral programs through stimulation of vitamin D receptors. That's one limb of a therapeutic strategy. Developing nasal vaccines is another, but that may be quite some time away. For that reason, it is very important to consider the use of various therapeutics to stimulate vitamin D receptors in the nasal epithelium. And just to summarize these key therapeutic concepts again. One, spike protein S1 toxin, wherever it's produced, can circulate and induce damage to cells, tissues, and organs, as well as producing endocrine impairments. Two, it is now known that Epstein-Barr virus and other viruses can be reactivated during COVID, and that Epstein-Barr contributes to increased COVID severity as well as long COVID. By stimulating vitamin D receptors, multiple pathogenic modules in COVID can be arrested. 4. The replacement of deficient vitamin D metabolites is a successful therapeutic strategy for COVID. So, replacing deficient vitamin D metabolites in the nasal epithelium, calcifediol 25D and calcitriol 125D, are likely to be successful therapeutic strategies for COVID. Can they be used for the treatment or prevention of COVID anosmia and or parosmia? So, looking at vitamin D metabolite therapeutics for COVID variants, just taking a break here to pause to say that this is the final section of this third part in this series, dealing with calcifediol and calcitriol treatments for COVID. Parosmia, altered senses of smell, now known as COVID smell, a multitude of symptoms which can impact sensory organs and functioning, now viewed as a classic sign of COVID infection. Typically, parosmia indicates that the sense of smell is returning, which is a good sign. However, it may last for an extended period of time, making some foods intolerable. Coffee is really the saddest thing for me because I really enjoy having a cup of coffee in the morning. Jennifer Spicer, MD, an infectious disease doctor at Emory University. So, the issue of parosmia and anosmia is complex because it involves multiple layers of neurosensory transduction from the level of olfactory receptors to the stimulation of olfactory neurons, which organized in the olfactory bulb, the first pair of cranial nerves. There are 12 pairs of cranial nerves, and the olfactory nerve is cranial nerve number 1. So it is important to recognize that there will be a whole layer of pathogenic modules that impact a sensory disorder like the alteration of smell or taste. And these papers are good starting points for that analysis. Again, damage to the olfactory epithelium in histopathogenesis has been analyzed in long-term COVID disease and how it pertains to anosmia. Olfactory dysfunction represents one of the most frequent symptoms of coronavirus disease, affecting about 70% of patients. So for that reason, anosmia and parosmia are very good biomarkers for the actions of analyzing the actions of COVID therapeutics, particularly those that are being delivered to the nasal cavity. Can boosting mucosal immunity with calcifediol 25D or calcitriol 125D improve outcomes, reduce the incidence of anosmia and parosmia, or stimulate the repair of the injured olfactory epithelium? Again, the discussion of these therapeutics needs to begin with an analysis of the biophysical chemistry involved in COVID pathogenesis of this olfactory epithelium and the biophysical chemistry of the applied COVID therapeutics. These topics will be discussed in a separate set of presentations. In closing, it's important to look at this paper from 2015, Vitamin D activation and function in human corneal epithelial cells during TLR-induced inflammation. And the authors emphasized that the corneal cells express the machinery, which means the hydroxylases necessary for vitamin D metabolism, which means the generation of 125D. And so they are able to convert metabolites such as D3 or 25D into 125D. But here, what they're doing is finding out when they give a pharmacological dose of calcitriol, can they upregulate the expression of an antimicrobial peptide, LL37? And indeed, yes, within 24 hours, this takes place. So the amount of LL37 being produced is substantial, whether the corneal epithelium was stimulated with 25D or 125D. And this provides increased hope that these two metabolites could be used for strengthening the innate immune defenses in the nasal epithelium and the oral pharyngeal epithelium. We're talking the delivery of these agents through nasal sprays and throat sprays. In addition, what's readily available right now is the use of oral calcifediol and oral calcitriol to treat COVID patients. And this protocol, I encourage viewers of this presentation to consult this paper and to look at the dosing and recognize that this is just the starting point. Calcifediol, calcitriol are lipophilic agents. The influence of body mass index, body mass, age, disease state, the hydroxylase levels in the affected tissues, all of this needs to be incorporated into future pharmacokinetic, pharmacokinematic, endocrinology analysis of what's going on. All of this is needed to help advance the use of vitamin D therapeutics to decrease COVID pathogenesis. But right now, upregulating antimicrobial peptides such as LL37 seems to be in play, or in the case of the nasal cavity, able to be achieved fairly easily through the use of aerosolized delivery. The impact of these therapeutics on anosmia and parosmia has to be lensed through what is already now known, recently discovered, about how COVID disrupts chromatin structure in olfactory neurons. Again, this is a very good paper dealing with these issues. As we look at airborne aerosol delivery, looking at the biophysics, the medicinal physics involved, whether we're using oral calcitriol or aerosolized calcitriol or calcifediol, inside outside pharmacology, using topical, I'm using that term loosely, an aerosolized spray delivered to the oral epithelium or nasal epithelium can be considered a topical application, whereas oral calcitriol, oral calcifediol, acting through capillary beds, is a way to ensure that the cells that are primary site of COVID infection are being adequately treated. And that is a potential pitfall for clinical trials of assuming that one drug and one formulation in one clinical trial serves as a good way to evaluate the therapeutic abilities of the agent. That is a pitfall. It is important to use multiple biomarkers to confirm delivery of the agents and physiological actions or inactions taking place once the drug has been confirmed to be delivered. So again, in closing, these four key therapeutic concepts. And the question, can vitamin D metabolite interventions be used to attenuate anosmia, parosmia, or to promote the regeneration of smell, sense of smell in post-viremic COVID patients. In the next section of this discussion, section 4, we will now look at the interactions between the vitamin D receptor signaling pathways and the toll-like receptors. And we'll be moving to a more cell-centric and sub-cell-centric integrated omics and integrated physiology form of analysis.